We've done a few of these together now, Tawfiq.
I'm going live, starting. Good evening, everyone. On behalf of New Country Healthcare and Vitabiotics, the producers of Menopause, I would like to extend a very warm welcome to all our distinguished doctors and healthcare professionals joining us today. My name is Tawfiq Ali, Country Manager for Vitabiotics at New Country Healthcare, and it's my pleasure to be your host for this evening's webinar. Thank you all for taking the time out of your busy schedules to join us for Menopause 360, Understanding Symptoms, Hormonal Care, and Natural Support webinar. Menopause is a significant phase in every woman's life, bringing it with a variety of physical, emotional, and psychological changes. With increasing awareness and evolving clinical evidence, it is more important than ever that healthcare professionals remain up to date with the latest approaches to menopause management. Today's webinar aims to provide practical, evidence-based insights into both hormonal and non-hormonal treatment options to help us deliver the best possible care for our patients. We are privileged to have two highly respected experts with us this evening. Our first speaker will be Dr. Malen Mubarak, consultant gynecologist and head of the Endometriosis Center at King's College Hospital, London, Dubai. And the second speaker will be Dr. Aparna Devi Gumma, consultant obs-gynae and deputy medical director at Mediclinic Parkview Hospital, Dubai. Our speakers and their topics will be formally introduced by our chairperson before their respective sessions. It is now my honor and privilege to introduce our chairperson for today's webinar, Dr. Ibrahim Abdurrahman. Dr. Ibrahim is a consultant gynecologist and advanced laparoscopic surgeon at King's College Hospital, London, Dubai. Dr. Ibrahim is a highly respected clinician and educator who doesn't need any introduction, especially in UAE special. And we are grateful to have him chairing this scientific session tonight. Without further ado, I would like to invite Dr. Ibrahim Abdurrahman to officially commence this webinar. Dr. Ibrahim, your floor is yours.
Thank you very much, Tawfiq. Thank you, everyone, for joining us. I know it's a little late, but Tawfiq said it all. Menopause has become a significant feature. A lot of women are getting issues. The research is overwhelming. With the introduction of AI, with the introduction of better analysis, we're getting more and more information, more and more guidelines coming out. Trying to keep up to it can be really overwhelming. So we are really honored to have two experts joining us in the field today. I've been fortunate and honored to work with both of them. I consider them colleagues as well as friends more specifically. The first speaker will be Dr. Malen Mubarak, who is my colleague. We're next door to each other at King's College Hospital. And the next speaker will be Dr. Aparna, who was next door to me at King's College, but she's now moved on to greener pastures at Parkview Hospital. So without further ado, let's start with Dr. Malen. Dr. Malen, please go ahead.
Thank you, Ibrahim, for the nice presentation. Let me just share my screen. Apologies, technology. So menopause symptoms are, there is at least 40 plus symptoms that start 2 to 10 years even before the onset of the menopause. Uh, eh, what we know, the hot flushes, night sweats. However, the impact on the brain is really, really amazing, including the brain fog and the memory effect, the emotional effect on women, and the cardiovascular and other impact. So the history of HRT is, we can't start talking about hormone replacement and the latest guidelines without looking at the history of HRT. The Women Health Initiative, the American study in 2003, have really messed up all the research in women's health and the funding for the research for menopause and hormone replacement, followed by the British Million Women Study. And unfortunately, now we understand the link between the breast cancer and the type of progesterone that had been used in the two studies, and as well the fact the American study had started HRT in women in their 60s and 70s, and we need to start HRT in women under the age of 60 and definitely under 10 years of the menopause. So the impact of the American study had, their amount of the research and the number of the clinical papers that had been published had been minimum. So interesting, the International Menopause Society, which I'm going to present today, their previous guidelines was published in 2016. So from 2016 until 2025, there was nothing whatsoever. This paper is amazing piece of work, the way it was designed, the number of the international expert in the field that was part of this study, and the way it was designed, looking at all the research and mainly research from 2016 onwards, and putting, around 340 points, around 34 sections. The important part of this guidelines and what we need to be aware, there is still missing information because of the lack of the research. If we are going to look into the impacts of hormone replacement on cognitive function, Alzheimer, dementia, any study needs to run at least for 20 to 30 years. So we don't have enough data. So, as I said, it's experts from all around the world that reviewed all the literature and then had been reviewed by reviewers. And then this is how we got the summary of this guidelines. So, the most important part in this guidelines is the recommendation. And I think the first part that we have to look into is the impact of the type of the progesterone that is used. So the guidelines had come up that the 3 safest progesterones or progestogens that does not increase the risk of thromboembolic events, neither the risk of breast cancer, are the micronized progesterone, dihydrogesterone, and the Marinacol. Hence, if you see from this graph that the medroxyprogesterone and noritestosterone are associated of higher risk of VTE and breast cancer. And these are what was used in the American and as well the Million Women study in the UK back in 2003, 2004. The impact on the VTE, there is no difference between oral or transdermal, even though the fashion now is into transdermal. However, there is no difference between both on the impact on the breast, neither the thromboembolic event. So, what did the IMS did come up with? You need to individualize the HRT to your patient. The type, whether it's transdermal or oral, it's individualized to each patient care. And both are effective in treating patient symptoms. So, regarding the point of vasomotor symptoms, hormone replacement are the most effective intervention that improves the vasomotor symptoms by 80%. Whether it's transdermal or oral is as effective. There is no other medication that is effective. And you need to start with the lowest dose. Too much of a good thing is not good. So we need to start with the lowest dose HRT in women who are under the, in women who are under the age of 50, under the age of 45, we definitely need to use a higher dose of estrogen. However, women in their 47, 50 and above, we need to use a lower dose of estrogen. And if we are looking at the tablet form, young women, they need 2 milligrams of estradiol to start with. However, the older women, 1 milligram usually is more than enough. However, you tailor the dose, depends on the vasomotor symptoms of these patients. You don't need to do an estradiol level. However, the IMS did state that if the patient is still symptomatic, doing an estradiol level can be helpful in managing their symptoms. And there is no effective level, there is no standard. However, anything between 30 to 350 is acceptable level, but we need to aim to maintain their estradiol level at the 50 or 60 or 100, depends on each patient. So that's an important point. So regarding HRT and osteoporosis, so 13% of the women develop hip fracture and peak age is 63 in comparison to only 3% of the men develop hip fracture and the peak age is 83. However, 50% of the women will develop vertebral fractures. And this is where the scoliosis, the low back pain, the nerve compression. And this is a huge numbers, and this is an important cause of morbidity in women. So hormone replacement is the best option for prevention and treatment of osteoporosis. The dose effect, so in the first 6 months, the 2 milligram dose, which is equal to 100 milligram of the transdermal estrogen, have a better impact on the bone density improvement. However, after 6 months, the 1 milligram and the 2 milligram have equal effect. So you don't need to increase the dose to improve a patient's bone density. So if we look at choice of hormone replacement, and I'm sure many of you, their patients come because her friend or her sister or whoever had been started on the bioidentical. There's a big fad, this bioidentical as transdermal. Some of the women, their absorption is not good, so you need to switch them to oral hormone replacement rather than increasing the dose of the number of the pumps of estrogen gel that you are using. In young women who are still having a period or their period is irregular, sequential oral hormone replacement is easier to manage their symptoms and their periods and the irregularity of their period. So you need to take into account risk factors of women when you are prescribing oral or transdermal. So it have to be individualized and of course patient wishes. That is important. So regarding the risk of thromboembolism, there is a lot of evidence that the risk is so related to the type of progesterone rather than estrogen. Estrogen on its own is not associated with increased risk of thromboembolic event. However, the transdermal have lower risk than the oral, and the IMS did come up with the fact that if a woman is high risk for VTE, such as obesity or even a previous history of known to be thrombophilia. Thrombophilia is not an indication for HRT. However, you need to use the transdermal. Even a patient who have a previous thromboembolic event as a DVT, and she is insisting to have hormone replacement after counseling, and of course you refer her to the hematologist for further assessment, you can start them on a transdermal. If a woman is on HRT and she develops a thromboembolic events on HRT, you don't need to stop her HRT as long as she is on anticoagulant. And I thought that is a very interesting point. So that's the risk of the VTE. It's so related to the type of progesterone. So utrogestan or the micronized progesterone and the dydrogesterone, as you can see from this graph, doesn't increase the risk of thromboembolic event in comparison to nortestosterone and medroxyprogesterone. Breast cancer, the data on the breast cancer comes from the American and the Women Health Study. They used medroxyprogesterone and they used nortestosterone. So this is regarding breast cancer. This is a meta-analysis by the Lancet, and it came up with the same thing, that it's the type of the progesterone that carries a higher risk. So risk assessment, what do you do? Before you start HRT, you need to do a full risk assessment for women you are planning to start an HRT. BMI above 40 is a contraindication. BRCA1 and BRCA2, endometrial cancer. Ovarian cancer is not indicated unless it is an endometrial cancer, and definitely we try to avoid it. Avoid using the HRT for women who had a very strong family history. I would send them to the breast cancer specialist to do full assessment of them and guide me. So this is an interesting study. It's called the Pro study. This study basically used hormone replacement for women who had prophylactic oophorectomy and mastectomy because they are BRCA1, BRCA2, and they found there is no increased risk of breast cancer in this group of women after 3.5 years of HRT. The benefit of HRT, so the timing is important. Estrogen prevents cardiovascular disease, prevents the development of type 2 diabetes in women who don't have it, prevents osteoporosis. And there is some data that it reduces the risk of Alzheimer and dementia. It comes mainly from the women who had HRT for premature menopause, because we have not stopped using HRT for this group of women after the American study. So the timing is important. The earlier you start, you don't need to start it once the period stops. Once a woman have symptoms, you can start the hormone replacement for her. That is another interesting point from the guidelines. It's interesting that this data come from the American and the million woman study, that hormone replacement reduces mortality in women for all reasons. What's other interesting point is women have 35% more risk of debilitating diseases, which are Alzheimer, osteoporosis, and cardiovascular. I never knew that cardiovascular disease is more common in women than men, and hormone replacement improves that. This is why the decrease of morbidity. Body mass weight. I think all of us, we get women and say, it's my hormone, I'm gaining weight. It's not actually. Estrogen reduces the insulin resistance. Testosterone as well plays a role in our insulin resistance. The drop of estrogen and testosterone makes women put, middle body fat. And even with the normal BMI, they have more cardiovascular risk. And that's why the guidelines stated its importance to focus on women's weight. And the guidelines even says that they can use the new weight loss medication. However, the increased body weight in women after a certain age is related. Our energy calorie requirement is lower. In women who is 25, we need 1,650 calories. Once we reach the age of 45, we just need 850 calories. And this is where the weight problem, rather than estrogen, and estrogen is not indicated for weight loss. Diagnosis of menopause and perimenopause and premature menopause. Any woman under the age of 40, you need to do FSH, LH if they have period irregularity. 25 FSH is usually diagnostic. You can repeat it after 8 weeks. It doesn't need to be repeated at the same time of the period. The problem, the estradiol level fluctuates, so you really need to rely more on women's symptoms, especially in the age of 42 and above. You don't need to do a hormonal evaluation for them. Lifestyle and diet and exercise, huge data being stressed on by the IMS, Mediterranean diet and exercising. And lifestyle, which we are talking about, smoking and alcohol consumption. Exercising is not walking for half an hour. Exercising is moderate cardiovascular exercising for 2.5 hours per week, which is brisk walking, running, cross trainer, and 2 sessions of resistance per week. That's what is exercising. So vasomotor symptoms, a cardiovascular disease, hormone replacement. Estrogen plays a role in the elasticity of our coronaries. At the same time, it reduces the amount of atherosclerotic lesions we put in the heart. Hence, it have a cardiovascular protection. And even in women who had a cardiovascular disease, estrogen can reduce their morbidity and mortality. And that is another interesting point. And estrogen reduces the cholesterol level. Oral estrogen is more beneficial when it comes to the cholesterol level. Genitourinary symptoms, beside the vaginal atrophy and the vaginal shrinkage and the dyspareunia and the recurrent vaginal infection, recurrent UTI and urinary urgency and urge incontinence, the truthal instability, is so linked to estrogen. Vaginal estrogen helps. Oral estrogen or topical estrogen sometimes is not enough. So you need to use vaginal estrogen. There's no evidence that vaginal estrogen increases the risk of breast cancer or thromboembolic event. They stress on the attention to the patient's sex drive, decreased libido, and the use of testosterone. No point of doing testosterone level because the current assay doesn't give you an accurate level of testosterone. Vaginal dehydroepiandrosterone can help vaginal dryness, but vaginal testosterone is of no value. They as well talked about vaginal laser, and all these aesthetic gynecology treatment is of no value, but I think the jury is still out there. For some women, it's helpful. This is something as well which is very interesting. Sarcopenia have never been mentioned before. Is the loss of muscle mass and strength. And this is estrogen related. However, estrogen does not improve the sarcopenia. What they advise is increase use of protein in the diet, exercising, strength exercising, and creatine. So that's for the sarcopenia. The skin, cartilage, and connective tissue, hair loss is so related to estrogen. Generalized joint pain. And another interesting point is when the level of estrogen drops, there is increased incidence of worsening of autoimmune disorders such as lupus and development of rheumatoid arthritis. Estrogen can improve their symptoms. Of course, it will not get rid of the rheumatoid arthritis, but it can improve their joint pains and joint inflammation, allowing them to use less medication. Cardiovascular disease, there is strong evidence. And type 2 diabetes, it reduces the risk of type 2 diabetes. Cognitive, we talked about thromboembolic. I don't need to talk about it. Central nervous system. So the data on Alzheimer, dementia, Parkinsonism, HRT reduces the incidence of Parkinsonism and dementia in women who had premature ovarian failure. We don't have enough big studies, and they suggested that we should not use HRT just for the sake of reducing the incidence of dementia. But women who start HRT will tell you it improves their concentration, it improves their memory level. The guidelines did state it does improve the brain fog. But when it comes to dementia and Alzheimer, I think we need more studies, but some of the observation studies showed a decrease in the incidence of Alzheimer by 45 to 70%. So, as I say, sequential HRT, continuous HRT have less incidence of endometrial cancer. A big Danish study showed there is no increased incidence of endometrial cancer in women who are on hormone replacement. If a woman have bleeding, and this is one interesting point in the new guidelines. So in women who's on continuous HRT, they now stated the cut point to use for investigation women of having unscheduled bleeding on HRT as 4 millimeters. So a woman on continuous HRT, 4 millimeter is the cut point. Woman on sequential HRT, you need to consider where is she in the cycle, however, 7 to 8 millimeter, or if the woman have like she's morbid obesity, adenomyosis, these are at higher risk of endometrial cancer. You need to take a PPL endometrial biopsy if they continue to bleed and adjust the dose of the progesterone. If they continue to bleed, then you need to do hysteroscopy. If they are high risk and the endometrium is quite thickened, you need to do hysteroscopy and endometrial biopsy. So ovarian cancer, minimal. I mean, the evidence is still not really solid, but potentially it might increase the risk of ovarian cancer, non-significant. Colorectal cancer, there is a huge ongoing study. It reduces the risk of colorectal cancer by 25%. Colorectal cancer is on the increase. We need to start screening patients from the age of 40. It's simple, it's stool analysis for occult blood. Quality of life, psychological impact, and this is something being stressed on, and this is really important part. I have women who had the thromboembolic event in the past, and it affected their work, their memory, their energy level, they were fighting everybody. And they insisted to start hormone replacement. Of course, I got the hematologist on board, and using HRT makes a huge difference to women's quality of life, and of course, husband's quality of life, the whole family. A happy wife is a happy life. So premature menopause, women who have premature menopause have increased mortality. Even using hormone replacement improves their cardiovascular problems and other morbidity. However, their lifespan is shorter than women who don't have premature ovarian failure. So prescribing HRT, it's important to assess women. Family history, personal history, make sure they had a pap smear, make sure they have a mammogram and breast ultrasound. So the estrogen, the higher the dose of estrogen, the more women have increased breast density. And that affects the quality of the screening. So you would need to use a double modality as a mammogram and breast ultrasound at the same times to assess to do breast screening. So ultrasound is important. If the woman have adenomyosis, you need to use higher, or fibrosis, you need to use higher dose of progesterone. You need to balance your dose of progesterone with the estrogen. So if you increase the estrogen level because the absorption is not quite good, or the patient is still symptomatic, you need to balance it with progesterone. If the patient is bleeding, you need to increase the dose of estrogen. So this is one of the available brands of estradiol 1 milligram and 2 milligram with dydrogesterone 10 milligram, the sequential. In a young woman, you start with the 210 as 2 milligram of estradiol and 10 milligram of dydrogesterone. In the 47 plus, you can start with 110 and then you increase the dose if they are symptomatic. Women postmenopausal, the continuous HRT 1.5 as 1 milligram of estradiol with 5 milligram of dydrogesterone. In some women, this dose is not enough, and unfortunately, we don't have a continuous HRT as 210, so I give them 2 tablets. So you need to monitor them. You need to see them of starting the HRT 6 weeks to 3 months, and once they are stable on the HRT, you can monitor them every 6 months. However, you need to warn them if they bleed unscheduled, they need to be assessed and have endometrial assessment and cervical assessment. So what regimes to use? And this is from the UK GP, British Menopause Society. Regime 1, women who had uterus out and cervix out, you can use estrogen only. However, the micronized progesterone can be helpful in women who are struggling to sleep. Women who are still having a period, even though it's irregular, you can use the sequential hormone replacement. Postmenopausal, continuous hormone replacement. Women on sequential hormone replacements, once they reach the age of 50 or 5 years on sequential HRT, you can switch them to the continuous. That's the new IMS guidelines. The bioidentical, which is the gel or the patch or whatever is available to you. You can use it with the Marinacol, or you can use it with the micronized progesterone or dydrogesterone. I honestly don't use any other hormone replacement, except there is one which I need to mention, which is it's a tablet form that have 1 milligram of estradiol and 2 milligram of Dynagest. Is fantastic for women who have adenomyosis, endometriosis, because if you use any other hormone replacement, their endometriosis, adenomyosis flare up, and it's difficult to control their bleeding. So this combination, which is in the UK, in Dubai, in the UAE, we call it Velbian. It's a fantastic combination for that group of women. So HRT reduces mortality. HRT, if it's prescribed properly, it is safe. And I think there is no guidelines to suggest when to stop it. Personally, I'm on it. I will never stop it until I drop that, because it really reduces the cardiovascular disease and reduces the mortality in women. But the jury is still out there regarding the Alzheimer's. Thank you very much.
Thank you very much, Dr. Marlene. It's a pleasure, as always, to hear you speak. A lot of information, a lot of guidelines, a lot of guidance on how to use the HRT properly. And I think that is invaluable. Thank you. If it's all right with everyone, we'll save the questions to the end. And I'll now call on my colleague, Dr. Aparna Guma, who will kindly give us a talk on the more non-pharmacological aspects of hormone replacement management or of menopause management. And I'm sure this will be entertaining, as it always is. Dr. Aparna, please.
Yeah, Thank you, Dr. Ibrahim. So it's a pleasure to be on this webinar along with you and Dr. Marlene. And thank you for Tawfiq for inviting me. I'm just going to share my screen. Just a second. Okay, can you all see my screen?
Yes, doctor.
Yes, it's clear.
Yeah, okay. So good evening all. Thank you for joining this webinar. I've been introduced already, so I won't go into the details. So I was given this topic, which is always, I'm very passionate about menopause, perimenopause, and HRT. I'm very pro HRT itself, but also interested to look at non-hormonal approaches and what is the evidence out there to recommend beyond hormonal therapy. What are all other options available? So let's start looking into it and who needs the non-hormonal treatment options. So before we go into this, like in bit more details, why do we need to know about this? As my colleague, Dr. Marlene, has already discussed about IMS recommendations and some of the menopausal symptoms, women do make up 51% of the world population. And the global population of postmenopausal women is growing as women are living longer. They are spending more than 1/3 to 1/2 of their life in menopause. So it's important that we are all educated and aware of, how to help these women. And about 25% of these women experience debilitating menopausal symptoms, according to the British Menopause Society. And it could be just the tip of the iceberg. They may be like, these are the women who are coming out and, asking for help and support, but there may be many women out there who are like, silently suffering. And below that, you can see like stress, reproductive staging, which goes through reproductive menopausal transition, perimenopause, and postmenopause, and how the hormonal levels are. So menopause, where does it come from? It's a Greek word, and it just means simply like cessation, like of the monthly periods. And of course, it's a natural event and transition of phase in the life and inevitable to all the women. And there is variable age groups. In Caucasian women, it's around 50 to 51, but in Asian population and African population, there are regional variations and it could happen early. And as my colleague Dr. Marlene has said, there is of course premature menopause or premature ovarian failure, which can happen if it happens too early before the age of 40. So the slide depicts how the estrogen levels are dropping. Like you can see from age 20 towards the age 80. So there is almost non-existent menopause like for estrogen levels, which will cause all the symptoms of the menopause and the side effects and the health risks that comes with it. So the slide is busy and we all have seen this slide. So there is numerous symptoms that happens like with menopause affecting from head to toe. So how do women suffer with this and how do they put up with this and what can we do to help them? So assessment of menopause, like we have seen in the previous slides as well. So, but it's important to understand each patient is individual and they have different symptoms. Like, so we can't assume that, all women have the same symptoms or they wanted to either have a HRT or non-hormonal treatment options. So it's important to understand the expectations. And I ask in my consultations, so what is bothering you most and how can I help you? How are you coping? What can I do to help you? So it's important to ask that question, understand the expectations and set these expectations at the beginning of the consultation. And along with this, we need to assess the personal history and family history of cardiovascular diseases, osteoporosis risk, and sometimes it could be perimenopausal symptoms, and she may be just bothered about the menstrual cycles more than anything else, or sometimes they may be more bothered about the VMS, vasomotor symptoms. There could be personal or family history of breast cancer. They may be worried about going to HRT, and there could be other gynecological conditions, or there may be history of migraine, strokes, or TIA. So it's important to do thorough history and detailed risk assessment before we go into any treatment options. So holistic approach is very, very important and essential in the management of perimenopause and menopause, and not having a sole focus on HRT or MHT, which is a good treatment and it's a good clinical practice to understand these expectations and set it up as per the International Menopause Society recommendations. So what are the non-hormonal treatment options? The prevalence of complementary and alternative treatment options are, increasing. And 30 to 80% of these women with hot flushes employ the non-hormonal treatment. So when we start the consultations, most of the time they come up with the negative publicity that's out there due to the WHO studies or Million Women study and say, doctor, I don't want to go on to HRT. What are other options I have? So the study of women's health across the nations has shown that 80% of the women do prefer to have non-hormonal treatment options to start with. And they prefer it to conventional therapies because they consider it to be natural and safe and having a positive impact on maintaining good general health. And they assume that there is no or mild side effects along with these treatments. Okay, so what is IMS, International Menopause Society recommendations? So women who are in perimenopause, who are under the age of 40 and have apparent contraindications for HRT should be referred to a center with a specialist with particular expertise in managing such women. This could be the woman who has a history or high risk of having a hormonal dependent cancer. They could have a thrombotic risk, cardiovascular high risk, or women who already tried HRT and they feel that they either have significant adverse side effects or could have an inadequate response. So these are all eligible to look into non-hormonal treatment options. So let's look at the myths and the facts. Okay, so are hormones the only treatment options for a menopause? Okay. Fact is, there are alternatives, both natural and medical non-HRT options. So there are medications which I will go into detail in next slides, but for example, gabapentin, which is anti-epileptic drug, and there is antidepressant medications like SSRIs and SNRIs like paroxetines and citalopram. We could look into these in bit more details, and CBT treatment and breathing exercises. And in 2023, FDA has approved fezolinetant, which targets the neurons that regulate the temperature and especially helpful with vasomotor symptoms. And for example, for vaginal dryness, hyaluronic acid is a recommended treatment as well. So let's look at the myth. Does all natural treatments are all safer? What do we feel? No, the fact is not all of them. Okay, just because something may be marketed as natural, that doesn't necessarily mean that it's safe. Unlike HRT, which has been studied extensively over a long time, most natural remedies haven't been thoroughly researched. There are some studies like clinical trials on some RCTs, but not all of them. So what can be done before going into the non-hormonal like herbal remedies or medical treatments? So lifestyle modifications is very, very important because it's very simple to adapt and change lifestyle habits. And if it's going to help the woman, why not? Okay, that could include socializing, being physically active, which can help with the mental health as well. And let's start looking at the diet. The healthy diet should include several servings of fruit and vegetables per day, and whole grain fibers, fish at least twice weekly, and reducing the total fat, and also reducing the salt, alcohol, and caffeine consumption. So this comes from IMS recommendations. So what is the impact of the diet? Let's start looking at the evidence. So vegan diet are more generally people who take higher intake of vegetables and fruits appear to have reduced symptoms of vasomotor symptoms. However, the available studies are small in scale, but it has shown the benefit. And what about Mediterranean diet, which is very widely popular for several different reasons? And Mediterranean diet has shown that there is a reduction of vasomotor symptoms. And there were studies done from Australian longitudinal study on women's health, as well as Women's Health Initiative dietary modification study, which was an RCT that analyzed the effect of dietary intervention on weight change. So this is a positive thing that, simple to adapt Mediterranean diet. And also DASH diet, which is mainly dietary approaches to stop hypertension, which is similar to Mediterranean diet. So therefore, it gives a similar benefits to vasomotor symptoms. And also along with this, the recommended dietary calcium intake from 700 to 1200 milligrams for women aged 50 and above. So this is the dietary and lifestyle factors. So when the woman is encouraged to have adequate fluid intake and healthy diet, adequate energy intake, and their sleep pattern is improved with regular physical activity, smoke cessation, these are all very helpful to manage the menopausal symptoms. So what about the exercise? Okay, exercise does benefit along with like stopping smoking, reducing alcohol and caffeine. So having a healthy diet, which we already looked at, how else can they manage the vasomotor symptoms? This is called layering, wearing loose clothes and sleep in a cool, well-ventilated room, and losing weight, especially if the BMI is high, this should be encouraged, and regular exercise. And what kind of exercise can we recommend to this woman? So regular exercise, like moderate intense activity of 150 minutes, which comes from CDC and World Health Organization recommendations. And the intensity of aerobic activity should take into account what they're used to, like older, gender-specific, and adults' aerobic fitness. And strength training is more important than aerobic exercises because that can, reduce the risk of sarcopenia, as Dr. Marlene was saying before. So in postmenopausal women, muscle wasting is very, very common. So strength training is very essential, and along with weight loss of 5 to 10%, because most of the women we see in the clinic complain about menopausal weight gain, especially midriff weight gain. And despite not eating more or, doing regular exercises, they still struggle with weight gain. So this could be the recommendation. That's what they needed according to the IMS recommendations. What about exercise? And okay, we looked at it. And what about yoga? Yoga can reduce the psychological, somatic, vasomotor, as well as the urogenital menopausal symptoms. So there was a systematic review and meta-analysis was done, which was published in 2018. It has shown that there are general health benefits, especially it improves the anxiety symptoms. And, with breath work and breathing exercises, it seems to be helpful in reducing anxiety associated with the menopause. What about herbal remedies? There are so many herbal remedies that are available. Some are well studied and has shown benefit, but not all of them. So evening primrose oil, and we will look in next few slides. There were like studies done which we can look into, but evening primrose oil is very widely used, as well as black cohosh, ginseng, St. John's wort, red clover. So these are all been, has been used, and health shops in UK, they sell a lot of these products. So there was a review which was published in Electron Physician in 2017, which looked at effective herbal medicines in controlling menopausal symptoms. So let's look at this review. So this is the medicinal plants which were studied in the clinical trials, and they look at the mechanisms, how they are working. So for example, sage is very widely popularly used in European countries. So especially for hot flushes symptoms, and it has shown that positive effect on nervous system, including the improved memory. And black cohosh is another one which is very, very commonly being used for several years, which is treated for vasomotor symptoms. And black seeds or nigella, which treatment of metabolic syndromes, and popular to, for women who are trying to lose weight. And let's look at other ones like, ginseng and red clover and soya. Soya, like most people would know, so estrogenic effects, but it need large quantities to produce any visible differences like with menopausal symptoms, but it is shown to reduce a small amount of reduction in vasomotor symptoms. So what about psychological therapies such as CBT, cognitive behavioral therapies? It has been demonstrated to improve sleep and mood and reduction of vasomotor symptoms. And hypnosis has been tried as well, again for VMS symptoms, and has been useful in reducing anxiety and improving the sleep patterns. So mindfulness and goes hand in hand with breathing exercises and relaxation therapies, which has also been studied in management of menopausal symptoms. Acupuncture, again, this has been studied. There was a meta-analysis which looked at 4 RCTs and 3 systematic reviews. It has shown that there is some effectiveness in reducing hot flashes, severity and frequency in both peri and postmenopausal group of women. So there is a European Society of Endocrinology, like clinical practice guideline, which looked at evaluation and management of menopause and perimenopause last year. So this is a studies published from them. So looking at alternative non-pharmacological treatments, so including CBT, hypnosis, biofeedbacks, relaxation techniques, mindfulness, yoga, including aromatherapy and physical activity. So there is some improvement in, vasomotor symptoms, and some of them has like some benefit about reducing the stress, but the results are inconsistent because these are not like a large group of studies done. So the studies will need to be more evaluated. So what about other medicines, plant-based derivatives, which we looked at already? So no significant effect on vasomotor symptoms. Again, black cohosh patients who used to take it used to say that they are benefiting from it, but the studies has not shown that much of benefit. So this comes from the British Menopause Society, which is prescribing alternatives to HRT, looking at gabapentin, pregabalin, clonidine, and SSRIs, as well as looking at fluoxetine, paroxetine, like sertraline, SNRIs as well. So let's look at these ones in a bit more detail. So SSRIs and SNRIs are a group of drugs which are used to treat for depression and anxiety and psychiatric issues, but as a benefit has been shown as a very effective non-hormonal alternatives to vasomotor symptoms. Suppose, for example, patients who had breast cancer and who are hormone dependent and not able to take HRT, this group becomes a lifesaver in those group of women by reducing the hot flashes intensity as well as frequency from about 20% to 65%. So how does this work? They affect the thermoregulatory center within the hypothalamus, and therefore decrease in the serotonin levels is affected by using these drugs. So they improve the symptoms of vasomotor symptoms especially. So what are these drugs and how effective these are? So once the women start using them, they feel relief within as early as 2 weeks of starting treatment. And there are different groups under SSRI such as fluoxetine, paroxetine, citalopram, and sertraline. And under the SNRI groups, venlafaxine and desvenlafaxine are very popular. And best safety profile comes with paroxetine, citalopram, and escitalopram. But there are certain side effects which are associated with this group of medicines, especially dizziness, gyrostomia, constipation, and lack of sexual interest. And some of the SNRIs can also increase the blood pressure. So if the patient is suffering with hypertension, this needs to be looked into. And why does the patient stop the treatment? Especially 50% of the patients stop the treatment at 3 months, and high dropout rates because of the side effects. And also the worry about withdrawal symptoms or like addiction to this group of medicines. What about gabapentin, which is very popular anticonvulsant medication? And systematic reviews have shown that gabapentin, if is used at a dose of 900 milligrams per day, reduces hot flushes very effectively. And it is compared to estrogens, appears to be as effective as estrogen. And we always start with the low dose medications with 100 milligrams 3 times a day for 3 days, and then slowly build up to gradually to up to 900 milligrams. And of course, there are side effects which could be like a rash or dizziness or weight gain, swelling of the lower limbs. And if somebody wanted to come off gabapentin, it should be tapered off slowly. So what is the other new group of medications? So eligenetant has been approved by the MHRA in UK for management of severe vasomotor symptoms. So let's start looking into this group of drugs. There are 2 medicines that are available, not yet available in UAE, but it's available in Australia and UK and other European countries. So fezolinetant, how does this work and what is this group of medicines? This is a neurokinin 3 receptor antagonist specifically designed to treat VMS. And it targets the neural pathways called K and DY neurons involved in the hypothalamic regulatory center, which controls the temperature. So it has shown to be very effective in reducing the frequency and severity of moderate to severe VMS. And therefore, the women tend to sleep better and reduce sleep disturbances, and therefore improved quality of the life and happiness. So the daily dosage is a single tablet of 45 milligrams. And main side effects could be nausea, fatigue, and rarely liver function can be affected. So it's important to regularly check this liver function test first month and 3 months and 6 months periodically thereafter. What about elinzanetant? Okay, this is working similar to the other drugs and targeting NK1 and NK3 receptors. And there were RCTs done, which has showed a significant reduction in both frequency and severity of hot flushes. And this could be a drug of choice in patients who are breast cancer population and suffering with a significant decreased quality of life with hot flushes and not able to have HRT. So this could be the medicine of choice and very effective. As soon as the treatment is started, within 1 week, there is relief of symptoms. So this holds promise in improving sleeping and improving the quality of the life. It has been approved in Europe and UAE, and hopefully it will be soon available in UAE because there are studies that are ongoing with the clinical trials. So what about breast cancer patients and SSRIs and SNRIs? Because this could be used in these patients, but one thing we have to be careful, and we always work together with the oncologists treating these patients. Patients who've been on tamoxifen, and there could be interaction with SSRIs and SNRIs. So therefore decreases the effectiveness from tamoxifen. If there are other aromatase inhibitors, then it's okay to take SSRIs and SNRIs. So it should be worked in a multidisciplinary setting. And there is some other group of drugs such as paroxetine and fluoxetine are very potent inhibitors of the enzyme in breast cancer patients, so they should be avoided during tamoxifen use. Citalopram and escitalopram are better choices in this group, as well as venlafaxine and desvenlafaxine. What about vaginal atrophy? Dr. Marlene has looked into this. I won't go into too many details of it, but let's look at the non-hormonal options. There could be moisturizers, lubricants, and phytoestrogens that could be used. And people has tried using like vitamin E and oral and vaginal probiotics and laser treatments. But hyaluronic acid has been shown in the evidence-based studies, like North American Menopause Society considers this as a first line of treatment by improving the moisture and giving a lubrication effect. So this systematic studies was shown where it reduced the risk of complications of dyspareunia. As well as they could also use like the vaginal DHEA as well as vaginal SERMs like osmofen can be used as well. So how does the laser treatment work? So this has been approved by the FDA, carbon dioxide laser treatment and erbium laser. It improves the vascularization of the vaginal mucosa and stimulates the new collagen and improves the glycogen. So therefore, the vulvovaginal symptoms and urge incontinence and stress incontinence or urinary symptoms frequently caused due to the vaginal dryness and lack of estrogen has shown significant improvement in the quality of the life and reduction of the UTI symptoms. So this comes from this is a slide most important to looking at the non-hormonal treatment options. We could see on the left side non-pharmacological treatments such as CBT, hypnosis, acupuncture, and then start looking into pharmacological at the simultaneously the group of drugs which we have discussed, SSRIs, SNRIs, and NKDY inhibitors, and managing the water-based vaginal symptoms, vulvovaginal atrophies. What about osteoporosis? So osteoporosis, again, a significant risk. Strength and resistance training and losing weight and stopping smoking is very important. So improvement of lifestyle habits, dietary vitamin D3 intake as well as calcium intake. And then we work together with the rheumatologist in women who is at high risk of osteoporosis to looking into other supplements. So of course, we can never forget Vitabiotics has come up with Menopause Original and Menopause Plus, which gives like improved energy levels, and there are several nutrients and vitamins and minerals available to help the woman going through the perimenopause and perimenopause. So menopause is not a pause, and there is no one-size treatment that fits all in managing menopause. So it's important to have a holistic approach to treat the treatment, find the treatment plan that is individualized and supporting the woman. And lack of menopause awareness and support is costing UK close to 10 billion. But if you look at it globally, you can imagine the large scale of the problem that affects. So by providing the right support and empowering and guiding the woman, we can manage the symptoms of menopause and let them enjoy a happy and healthy life peri and post-menopause. So these are the references. So you can start looking into this, like if you needed more information about. Probably that's my last slide. So thank you very much for having me as a speaker, and hope you all has learned non-hormonal treatment options.
Thank you very much, Dr. Aparna. Excellent as always. Very informative. Thank you very much. I'm going to go to the questions now. First one from Dr. Mansa. Hi, Dr. Mansa. HRT prevents osteoporosis. Any role in osteoarthritis, which is age-related?
estrogen plays a role in the lubrication of our joints and and cartilage. So it tends to improve the inflammation in the joint and improve joint pain that a lot of women in perimenopause and menopause suffer with. There is a lot of evidence of that.
Okay, thank you. Next question is anonymous. 56-year-old obese patient, not diabetic, postmenopausal women, no HRT started yet. What would be the ideal approach now?
I think from the point of view, the cut line for the BMI is 40. So under the BMI of 40, you can use a hormone replacement, as long as she is been menopausal under 10 years and under the age of 60. Definitely, you can start hormone replacement, and the safest one for her will be transdermal, whether it's the patch or the gel. However, because there is a huge amount of circulating estrogen in her body because of the fat, you need to put her on high dose of progesterone, whether put a Mirena coil if it is enough. Maybe these women tend to need the Mirena coil and a little bit more of oral micronized progesterone. You really need to do a good balance for them.
Thank you. Thank you. I have a question now, which is really for Dr. Aparna.
Mm.
And Dr. Marlene, there is a patient who has had breast cancer. She's a therapist of some kind. She's done all the research. Her oncologist has declined hormone replacement for her, but she's insistent on it. Where do we stand ethically at prescribing this?
Okay, so this is always a tricky one in the sense we have to work together with the oncologist, and because the hormone receptors, like hormone-dependent cancers, there is always a risk of recurrence. But then again, you have to balance the quality of the life, and maybe one of the options is like with the new medicines that is available, so as maybe she's not aware of other options, alternative options, such as, L-injectant or SSRIs. This is a good choice, depends upon what is the symptom she's struggling with, because if she's struggling with vasomotor symptoms, this is the best choice to try and, keep reducing the risk of recurrence of breast cancer. And again, like vaginal estrogen has shown that there is no increased risk of recurrence. So that could also help relieve some of the symptoms. What do you say, Dr. Marlene?
If she is estrogen receptor and progesterone receptor negative, there's no contraindication to HRT. And I have few patients who are on it that are breast cancer undergoing chemo at this moment of time. But if they are estrogen and progesterone receptor positive, as Dr. Aparna said, there is alternative. We discuss with them. If they are, they have no benefit from vaginal hyaluronic acid, you can do a short course of vaginal estrogen, but I'll be reluctant to give them estrogen and progesterone if they are ER/PR positive.
Thank you very much. I think we're all in agreement. I'll feed back to the clinician who was asking. I have a question now from Dr. Ghada Ibrahim. Thank you, doctor, for guiding about the modulation of estrogen doses. My question is about progesterone, utrogestan. When to use 100 and when to use 200?
Okay, you have always to start with the lowest dose of HRT. What makes me to decide on the dose of the progesterone is the ultrasound scan finding. If the uterus is normal size, the patient doesn't have endometriosis or adenomyosis, I would use 100 milligram of utrogestan, micronized progesterone. If the patient have adenomyosis or known endometriosis, I would put them on the 200 milligram. If they are troubled with the bleeding, I will increase the dose. So that's what decides on whether it's 100. However, if I need to increase the dose of the estrogen because they are still having hot flushes, then you need to increase the dose of the progesterone. It's a balance between the two.
Thank you. So, Dr. Aparna, you've given us a talk about non-hormonal treatments, but I'm going to ask you a hormonal treatment because I'm
Yeah,
sure you
sure.
use them as
Yeah.
well. Treatment for postmenopausal urge and urge incontinence.
Yeah. See, this is all due to the estrogen deficiency, as we all are aware. So vaginal estrogen could be the benefit, like as well as having the laser therapy. So most of it is like dryness related and local estrogen deficiency and depletion of the glycogen. So by using the local estrogen cream treatment, and if they are on like, the HRT, systemic HRT, that would also help, but more targeted local estrogen cream that would help reduce these symptoms, of course, along with physiotherapy. And, if they're high BMI, then losing the weight and laser treatment also will improve and benefit these symptoms.
Thank you. Now, I have a question for both of you, if that's okay. Can a person with endometriosis and now with, I'm assuming that it's a history of endometriosis, and now with a bladder endometrioma be given HRT? Dr.
Okay.
Marlene, do you want to start?
There's no contraindication to HRT for women with endometriosis. However, your bioidentical HRT is not going to work for them. The micronized progesterone and dydrogesterone is very mild, is not going to balance. This is where the one that I mentioned at the end, which in this country called Velbian, is estradiol valerate 1 milligram with Dynergist 2 milligram, can be a very good option, which I use it for women with endometriosis at all ages, and it had reduced the size of chocolate cysts and had improved their pain symptoms. So that will be my option for somebody like her.
Okay.
I agree with Dr. Marlene. Yeah, I agree, definitely. It seems it will be a better choice for this group of patients.
Okay, I have a question from Dr. Susan Varghese. Would you give testosterone to a patient with hormone-dependent breast cancer?
Well, hormone-dependent breast cancer, it's okay. The IMS is very clear. There is no advantage of giving testosterone without estrogen and progesterone. So, no, I wouldn't give them testosterone.
Okay.
What do you
Dr.
think, Aparna?
Yeah, I agree, Dr. Marlene. I mean, the only time I would consider very short course is, only libido related issues. Like that is the only time, like in a very short course of it. But I agree with you because it depends on what are the symptoms like she's looking at, like, otherwise there is no advantage of giving testosterone on its own.
Thank you. I have an interesting question now for you, Dr. Aparna. Can you elaborate on the management of osteoporosis? This is from Dr. Ravi Chandra Jayasundar. Can you elaborate on the management of osteoporosis using bisphosphonates?
Yeah. So ideally, like I wouldn't be prescribing biphosphonates. Like this is why I said we work together with the rheumatologist who will be doing the prescription. So once we diagnose, like, osteoporosis, is important that, identifying the risk factors, say the personal history or family history, such as a low BMI and smokers and family history. So this is important to identify this with DEXA scan and changing lifestyle, stopping smoking, and then vitamin D and calcium supplements. But when we have to go on to biphosphonates, like the practice is in UAE or UK is different to maybe some other countries, we wouldn't be prescribing directly to them. We'll be referring to the rheumatologist to work together with them. So because there are new options as well, there are like denosumab injections, which can be given twice a year, whereas compared to some injections could be given like monthly as well. But MHT or the HRT is like, very good treatment options. Once you identify risk factors, before going on to like, biphosphonates, MHT would be a number one choice to prevention as well as the initial early stage treatment.
Thank you. I have a question that's interesting from Dr. Nasreen Al-Mustafa. From Dr. Pooja. Hello, doctor. What is your opinion regarding vaginalized micronized progesterone? Dr. Malin?
Well, you can use the micronized progesterone, vaginal or oral. There is no difference. Cyclogest, or which comes at 400 milligram vaginal, is actually a micronized progesterone. So yeah, you can use it vaginal.
Yeah, it's the patient preference. Like, some patients prefer to use vaginally, like the utrogestan as well. So instead of oral route, whichever they're comfortable with. So it
Yeah.
doesn't make any difference in the absorption.
Okay, I'm sorry. This is an interesting question for you, I think, Dr. Aparna, from Dr. Nahid Kapadia. What is your experience with lactic acid vaginal gels such as Gynofit in women who can't use vaginal estrogen?
So it acts as a moisturizer, improving the lactobacillus. So I do give it to the patients, like where vaginal estrogen is a preferable option. But if the patient is not keen on using and they're suffering with the vaginal dryness, lactic acid or combination of hyaluronic acid is much, much better. If the hyaluronic acid gel is not that would be my preference to use. If not, then we'll go for lactic acid.
Okay, and the question from Dr. Nasreen Al-Mustafa was, is our goal to treat symptoms only or protect the heart, bone, and brain? Dr. Malay?
What's the question again?
Is our goal to treat symptoms only or protect the heart, bone, and brain?
Our aim is to improve the quality of life, reduce the morbidity and mortality, and that is our aim. So it reduces the cardiovascular disease, the risk of type 2 diabetes. It reduces the risk of osteoporosis and all the complications of it, joint pain, the brain impact, the psychological impact, the sleeping. So yeah, it's all rounder. I call it's a Botox that is not for your face, but it's for every organ in your body.
Okay, thank you.
I
have a question.
100% agree. Yeah, I 100% agree with my friend Dr. Marlene to say, why not, anyone wants to have any doubts about it. When you start listing all the benefits of HRT that comes with it and compared to the latest information that comes from to see how many benefits it has, we have to look at it, why people are still worried or scared about using MHD.
Absolutely. So the next question I think is for both of you, and maybe you can start, Dr. Aparna. From Dr. Alkeen Sahib. Women with only reduced libido and no other symptoms, what would be the ideal regimen and how long can you give testosterone?
So again, like the MHD, people worry about, unlike MHD, there are different things patients worry about, breast cancer and other risks. Whereas testosterone, what we find, Dr. Marlene will agree with this, like, most of them, the first question they ask is, okay, when we start thinking about it, like, okay, MHD would help, but testosterone is the ideal treatment in the lower libido. Okay, but estrogen and progesterone levels has to be good in these patients to have the benefit for testosterone. But the first thing they worry is, doctor, I don't want to be a man. I don't want to develop beard. I don't want to develop a hair, because none of these treatments comes as a licensed treatment. When you read the label that comes with it, it doesn't say like it's specific for menopausal patients or perimenopausal patients. Even the note says what is used either in testogel or testo-1 preparations is very, very low. And there is no evidence to say that they develop like beard or chin hair or like, they're going to have a horse visor man. The women do worry. So there is no time limit on it. As long as the patients are getting the benefit and, not developing any significant side effects, which they shouldn't do, I don't put a time scale on it.
Thank you, Dr.
What is
Marlene?
your experience, Dr. Marlene?
So I agree with you, Dr. Aparna. So vaginal dryness and vaginal atrophy and dyspareunia is one of the reasons that puts off women of having intercourse. So systemic HRT on its own without testosterone improve the sex drive in like 80% of the women, and only 20% would need extra testosterone. So yeah, that's how I will counsel my patients.
Okay, thank you. Can HRT be started 15 to 20 years after starting the menopause? Dr. Marlene, you can start, please.
Yeah, there is. So if the patients have no contraindication, you've screened her for breast cancer, and the patient is suffering with the, hot flushes, night sweats, the vaginal dryness, uh, the joint pain, the brain fog, you counsel them that there is increased risk of strokes and heart attacks if you start HRT later than 10 years. However, that is a part of the IMS. You can start them if they are aware of everything. You can start them on topical bioidentical HRT. It does not increase the risk of any thromboembolic events um, as long as they are fit and healthy. This is a new thing in the IMS, by the way.
Thank you, Dr. Aparna.
Yeah, so the maximum benefit is if they are within 10 years of the menopause. So when this question is asked, is this patient like struggling with perimenopause or had a premature ovarian insufficiency? Like maybe she's diagnosed at the age of 40, but didn't manage to go on to HRT for whatever reasons. Ideally, the HRT has maximum benefit below the age of 60. But if somebody is above 60 and still considering struggling with symptoms, then adequate counseling is needed. And they still do have some of the benefits, like not as maximum benefits below the age of 60. So again, it's all individualized, personalized discussion and looking at the risk factors. Then I wouldn't hesitate to put them on a MHT if it is going to be beneficial for them.
Thank you. And we have a question that I think probably even I can answer. Hypertension and diabetes, are they a contraindication to HRT?
Definitely no. Actually, they can be beneficial in reducing the atherosclerotic lesions that these women put in the heart and reducing their cardiovascular morbidity. It's definitely recommended by the cardiologists who have an insight. The problem is there is not many doctors who have an understanding of the benefit of hormone replacement and who can help you to manage these patients.
Dr. Aparna?
Yeah, completely agree. So overall mortality is reduced in this group of patients when they do go on to MHT, of course, along with lifestyle modifications. So, it's going to be beneficial rather than detrimental in this group of patients.
Thank you. Now I have, I think, two more questions. First is Dr. Umber. Patient is 46 with amenorrhea for 6 to 7 months, family history of premature menopause, having disturbed sleep, dryness, dyspareunia, low sex drive, and hot flushes, brain fog. What is the best choice and what duration? Dr. Molia?
I will counsel the patient. My first choice would be to put them on oral. I've been switching a lot of patients from transdermal, by the way, into oral. The problem with the transdermal, the gel, the pump, which have 75 milligram as a starting dose, there is a problem with the absorption. And they tend to have trouble with the bleeding. And she is perimenopausal, not menopausal. So I would put her on oral, depending on the severity of her symptoms, whether it's estradiol, dydrogesterone, 110 or 210. That would be my first choice for her.
Thank you. I'm reneging on the deal. We've had a few interesting questions, so I'm going to ask them all. Can tibolone be used for for hot flushes?
Okay, I'm going to be very clear and politically incorrect. I am against tibolone. Tibolone is associated with increased risk of breast cancer. It's fantastic for vasomotor. There is no evidence whatsoever it have beneficial in reducing the cholesterol level, nor reducing the cardiovascular disease, nor a positive impact on the brain at all. So I've not used it and I will not use it.
Dr. Aparna?
Yeah, completely agree. I mean, tibolone was one of the choices, maybe like 12, 14 years ago. And there are much more safer options with
Yeah.
reduced risk profile has come into the market. And, there are several choices available. This was the only medicine which was available like 10, 15 years ago, and we have moved on. So this question keep coming up in our webinars as well as when we do annual updates. So again, I stand with Dr. Marlene with this to say we have much better choices and less risk profile medicines available. So it's not a preferred choice any longer.
Thank you. So what are the chances of spontaneous pregnancy in women with premature ovarian failure on HRT?
Oh, quite good.
Yeah,
I've
quite good.
written an article. I've written an article of a woman that I sterilized myself, did bilateral tubal ligation after 3 children. She had premature menopause at the age of 23. We put her at that time on progliton. She got pregnant first time, second time, and third time. So dydrogesterone does not suppress ovulation. This will be my first choice combination medication of estradiol dydrogesterone tablet 210, the high dose, because it does not suppress ovulation, and you tell them this is not contraception and they can get pregnant on it. So
Sorry, please carry on, Dr. Mali.
no, I was just asking Dr. Opara what she thinks.
Oh, definitely agree. I have 2 patients who are with premature ovarian insufficiency at the age of 32 and 33, being on HRT, and both of them are pregnant now. I have seen a large number of group of women, and they get irregular periods once in a while, maybe after 2, 3 years, they get a random ovulation happens. So there is always a chance of pregnancy, and we call it the magic or miracle conception in this group of women. But I always tell them it's not a contraception. You can get pregnant. If God is on your side, it may happen.
Thank you. Now, I'll ask one question, Dr. Parna, one Dr. Marlene. Dr. Jaya Chatterjee, is there any particular part of the body where you would advise patients to apply the patch or gel? Dr. Parna.
Yeah. So ideally preferable if they use on the lower abdomen or the thigh, so it depends upon which country you are living in as well. Some hot countries, like where the patch may not stick very properly. So, and sometimes there is a small risk of rash as well. So it should be on a flat surface, ideally on the thigh or lower abdomen where it should be stuck properly.
Thank you.
I mean, Davina McCall, which a lot of British educated people know, she puts it on her bum, just under the, above the bikini line. And it's fantastic, but you need to change the position every time. As
Thank
left, right, left, right.
We had the same question about tibula, and we'll leave that. Can I ask Dr. Marlene about the cutoff of endometrial thickness while on HRT?
That is, you know what? I've actually, you remember when we did our first menopause conference last year, and I asked you to talk about postmenopausal bleeding. There is nothing in the Royal College guideline or anywhere about the endometrial thickness as a cut point. The IMS now had come up with the cut point of 4 millimeter
On
for
HRT?
on menopausal women on continuous HRT.
Okay.
And 7 to 8 millimeter on sequential HRT. However, if they have risk factors, so they say 4 millimeter abnormal bleeding, increase the dose of progesterone. If they bleed again, take endometrial biopsy. However, 4 millimeter with abnormal bleeding and other risk factor, do epipel endometrial biopsy. If they bleed again, do hysteroscopy. And the same thing applies for on sequential. Consider changing them to continuous or increasing the dose of progesterone. If they have risk factor, they continue to bleed, you need to do a hysteroscopy. Very interesting. Finally, there is data to guide us.
Okay. Thank you very much. I think we've exhausted all the questions that are there. Can I maybe just ask for closing remarks from both of you?
I would want to say thank you to Tawfiq and to you, Dr. Ibrahim, for this fantastic webinar and the opportunity to, spread the word about women's health and quality of life. And thank you for everybody who attended.
Thank you, Dr. Marlene. Dr. Aparna?
Yeah, again, thank you, Tawfiq, continuously trying to raise awareness through the menopause webinars and menopause conferences. And for you, Dr. Ibrahim, always chairing and moderating our sessions and, guiding us through the questions. So I think there's still a lot more needs to be done, Dr. Marlene, and I know myself, we will say that we carry on raising awareness and educating the healthcare professionals so that wherever you are in the world, you are attending these conferences or webinars, please carry on supporting and guiding the women through with this knowledge you have gained through, and we will carry on working through to raise more awareness.
And I
Thanks.
just want to say a last word. Please join us on the 23rd of October on our second menopause conference that the four of us are working on organizing.
Thank you. Now, I'd like to triple the comments made about Tawfiq's efforts. Always fantastic, always a great session. Thank you very, very much, Tawfiq. I'd like to thank all the attendees. I know it's late for you, but thank you for attending. Thank you for staying online. Thank you for paying attention. And it's been my pleasure to listen to two great talks. I'll hand back to Tawfiq. Thank you very much.
Thank you very much, Dr. Aparna, Dr. Marlene, and Dr. Ibrahim, for making this session a great success. So catch you later again, 23rd of October. Please join us physically, hopefully in Dusitani. So I will be sending the invitations to you as well. Yeah. For this program, so you'll be receiving the certificate by email within a couple of days, inshallah. Thank you so much for joining. Have a great night to all.
Thank you. Thank you very much.